On behalf of the Institute, it is my proud privilege to welcome you all for the 36th edition of the Sarveshwari Memorial Oration in Neurosurgery. And to begin with the proceedings, I request Professor B.S. Sharma, in absence of the director, to welcome the orator with a bouquet, please. So to take the proceedings further, may I now request Professor Vivek Tandon to carry forward with the proceedings.
A very good morning to all of you. And this is the 36th Sarveshwari Memorial Oration. And to tell you about the oration, I would like to invite Professor Sharat Chandra.
Can I have the first slide, please? So good morning. As is customary for every oration, we need to tell a few words about this oration. And even though this oration had a very humble beginning, but it grew to have a very big legacy. And so I will be showing a few slides about the 36th, about Sarveshwari Memorial Oration in general, and the 36th oration. Can I request the audience to please keep silence? इसको आगे कैसे करते हैं? Can I? So, Mrs. Late G. Sarveshwari was born on 10th June 1947. She was the eldest child to Mrs. and Mr. G.S.K. Rao, who was an electrical engineer from Bangalore. She had her early schooling in Andhra School, Delhi, affiliated to CBSE. And thereafter, she did her BSc honors in 1968 from Delhi University as a student of Merenda House. It's not moving forward. She was an excellent student and stood first in the Delhi University in MSc Botany. She was awarded Panchanan Maheshwari Memorial Prize for her achievement. Soon after her MSc, she got married and settled down to a happy family life. So between 1968 and 1975, she was a proud mother of 3 children. The first symptom of brain disorder was noticed in May 1974 in form of severe headache and loss of consciousness. The project doctors of Balco at Korba, where her husband was employed, referred her case to AIMS. At AIMS, she was unfortunately diagnosed to have malignant astrocytoma. She was operated upon 12th March 1976 and a radical excision of tumor was performed. And Professor P.N. Tandon, who is the founder of our department, was the surgeon who did it. This was followed by radiotherapy. She made a quick and complete recovery, but the tumor recurred and she succumbed finally to her illness on 3rd February 1977. The oration was instituted through a munificent grant by her loving husband. The first oration was delivered in 1981 by Professor Christian Kristiansen, no other than Professor Christian Kristiansen from Oslo, Norway. And over years, several distinguished orators have given the orations. To mention in series, so one of our residents has put up the slides. So in 1983, initiated by Professor Christian Kristiansen. In 85 by Professor Dr. R.P. Sengupta from UK. Professor Theodore Rasmussen in 1986. Dr. K.V. Mathai, who happens to be one of the founding neurosurgeons for the country in the year 1988. Dr. Jacob Abraham, who established the Department of Neurosurgery at CMC Vellore, again for the oration in 1990. Professor M. Shambasivan in the year 1992, Professor B.S. Das for the year 1993, Professor Hugh Cockham for the year 1996, Professor David Mendelow for the year 1997, Dr. Alistair Jenkins for the year 1999, Dr. Alan Crockett 2001, Professor Yoshio Suzuki 2002, Professor Albino Bricolo 2003, Professor Hirotoshi Sano for the year 2004, Professor Tetsu Kano for the year 2005, Professor Roberto C. Hiros for the year 2006, Professor Arnold Menezes for the year 2007, Professor Brian Brophy for the year 2008, Professor Anil Nanda for 2009, Professor Majid Sami for the year 2010, Professor Andrew Kei for the year 2011, Professor Takeshi Kawase for the year 2012, Professor Jua Hersnemi for the year 2013, Professor Henry Schroeder for 2014, Professor William Caldwell 2015, Professor Katsumi Takizawa for 2016, Professor Charles Teo 2017, Professor Richard Fessler 2018, Professor Fred Gentili 2020, Professor Franco Servade, the earlier president of WFNS 2021, Professor Mitch Berger 2022, Professor Takeo Goto 2023, Professor Tanikawa for the year 2024. And this year, of course, we are very, very pleased, happy and honored to have Professor Satoshi Kuroda. And briefly, we will have a short introduction about this year's orator.
A very good morning to all of you. And it's a privilege has been treating our people and has been providing them with not only mentorship, but with love and respect. Is one of the most famous quotes that Ramesh told me is that he loves the Satoshi restaurant, and he famously says, Satoshi misses Santoshi number of times. He loves the Indian food, and he takes whosoever is there, he takes them out for the dinner. His journey continues. His a commitment, always exploring, always teaching, always learning. Mentorship, innovation, and collaboration are the key words which defines Professor Kuroda. He has life beyond neurosurgery, and that's the best part. Not only we should be learning and picking up skills about neurosurgery for him, but how to lead life. I think this is one thing we should be learning from him. He is an avid mountaineer. He goes for climbing. He is a martial arts champion, and he practices everything with a degree of refinement and skill. And that's the best part. And you can see here, he is an avid photographer. Some of the pictures that I've seen, they are just not photographs. If only you meditate and you see things differently, only then you can click these photographs. That's the beauty about it. The same precision that he brings to neurosurgery, he brings to the artistry. That's the best part about Professor Kuroda. He is blessed with a happy family. His wife, who's seen here, Mrs. Kuroda, and I'm 100% sure that the foundation of life, well-lived, family, gratitude, and shared dreams is only possible if you have a very loving wife, and he has 3 loving daughters as well. This is my last slide, which says he is the last samurai who is honoring tradition, pioneering future. Professor Satoshi Kuroda embodies excellence, dedication, and he is a timeless warrior spirit in the cerebrovascular surgery. But I'm 100% sure that Professor Kuroda is not the last samurai. He has trained the next generation. And with these words, I would like to welcome the great man of the bypass surgery, who has defined this, where millimeters decide about the destiny. Professor Kuroda has shown us that excellence is not an act, it's a discipline. Today we welcome not just a surgeon, but a teacher who has shaped generations. Thank you. Welcome, Professor Kuroda.
Thank you very much. Excellent introduction. Thank you very much. Uh, this time, at first, I would like to express my extraordinary gratitude to this invitation as a memorial orator. I'm very happy, very Satoshi, and very proud to be here, to be invited as Sarveshwari Memorial Orator. I'm really happy. So thank you very much, everyone. Previously, seven Indian samurai, kindly visited my university hospital. Maybe they could learn some small things from us, but I could learn a lot of things from these seven Indian samurais. I could really enjoy with them, and I could enjoy many discussions about neurosurgery with them. And, another Indian samurai will come to Toyama very soon, maybe September. When using this opportunity, I decided to look back my 40-year history as a neurosurgery. For these 40 years, I wanted to be a scientific neurosurgeon. I mean, clinical questions must be or should be solved by basic research, and the findings must be returned to the patient. So surgical technique is quite important or essential. Otherwise, we cannot treat the patient. But deep thinking and scientific thinking would be also very important to develop new neurosurgical treatment and advance our total power to neurosurgical disorders. This is my brief history as a neurosurgeon. As kindly introduced, at first we were educated at Hokkaido University for about 9 years. And then I learned basic research at Lund University. Lund is located in the very southern part of Sweden. I could learn many things there. And then I came back to Hokkaido University, Sapporo, and I could work as a chief surgeon or as principal investigators of translational research. And then, very fortunately, I could move to Toyama as a chairman at the neurosurgical department. I could advance the neurosurgical technique there by operating on spine patient, MVD patient, skull-based patient, as well as cerebrovascular disease patient. And also, I was happy to conduct several multi-center studies. as I told you in this morning, my history cannot be told without him, Professor Kamiyama. Was the first time I met him when I was a medical student. He was very young. He was just 38. But his surgical skill was very, very surprising. I was very shocked. And very quickly, I decided to be a neurosurgeon and learn everything from him. It was a very, very big chance for me. And at Hokkaido University, fortunately, I could get a PhD degree. At that time, my research term was near-infrared spectroscopy to monitor the ischemia or hypoxia in animal and humans. Now near-infrared spectroscopy is very popular over the world, but about 30 years ago, this modality was unpopular. But we can check the status of cerebral oxygenation non-invasively. And so this is the data of carotid endarterectomy. When we clamp the carotid artery, oxyhemoglobin is enough decreased, and the deoxyhemoglobin quickly increased. At the same time, N20 this is the data of carotid endarterectomy. When we clamp the carotid artery, MCA velocity hemoglobin TCD decreased quickly, and the deoxyhemoglobin quickly increased. So near-infrared spectroscopy N20 is very, very sensitive modality to check status of MCA velocity oxygenation TCD non-invasive quickly disappear. Nowadays, this monitoring so is near-infrared spectroscopy is very, very sensitive modality to check and also I would like to determine non-invasive some surrogate nowadays this monitoring is very, very popular during the candidate of STMCA bypass. And also I would like to determine I could some divided carotid occlusion patient choose a candidate of STMCA bypass, normal CBF, and normal diamox reactivity. I could divide it normal CBF patient and decrease diamox normal CBF and normal diamox reactivity as type 1, and reduced CBF normal CBF and reduced diamox reactivity as type 4, and reduced CBF. And nowadays this is called as Kuroda for type grading. And so on. And when we treat the nowadays this is called as Kuroda's just med grading. Types and when we treat the carries very high just med risk of a recurrent ischemic stroke. Carries a very high risk. We decided recurrent ischemic type 3 patient should undergo. We decided that the type 3 patient should undergo STMCA bypass. And then I could have and then I very good opportunity could have run very good opportunity to experiment in Sweden. Experiment in Sweden. Professor Kamiyama is very great. Professor Kamiyama is very giant. Very giant. Another giant is Professor Busihwa. He has established almost everything about CDF and metabolism in cerebral ischemia. He's really giant. I'm very sorry that he has been deceased before. In Sweden, I conducted basic research of regarding reperfusion after cerebral ischemia, MCA occlusion. And pre-radical scavenger NXY 059 very effective. But very unfortunately, subsequent RCT in the United States and Europe could not show the beneficial of this agent at the phase 3 studies. But anyway, I could run from Professor Silver how to direct the experimental translational study as a principal investigators. It was a very good opportunity. Then I came back to Sapporo University, and I developed MCA bypass and EDMOPS as a novel indirect procedures. Previously, we just used temporal matter indirect bypass. So we could not improve the cerebral hemodynamics in the ACA territory. So I decided to use the frontal pericranium as alternative indirect tissue. As I told you before, in this morning, frontal pericranium is receiving blood from the ophthalmic arteries. So frontal pericranial flap is quite important in skull-base surgery of anterior cranial fossa. Frontal pericranium can be useful in moya surgery. Blue dot line show the temporal linea temporalis. So if we can use frontal pericranium indirect bypass, we can extend the cranium to the medial side of front area. Then we can cover the brain surface using temporal muscle and also frontal pericranium. This is the MRI angiography and the SPECT. I did the right side surgery. Just one day after surgery, STA started to markedly dilate. Maybe it's up to demand of hemisphere, and also now we can see a little bit hyperperfusion in the MCA territory. But 1 week after surgery, CBS almost normalized both in MCA and ACA territories. This is preoperative couch angiogram. After surgery, such dangerous moya vessel decreased. Markedly decreased. And you can see the very developed arteries from the ophthalmic artery. This blood flow is supplied from the frontal pericranium. And also external carotid artery shows very nice patency of the Viperus, and also a direction of a deep temporal artery through the temporal muscle. So we can obtain very nice revascularization of the operated hemisphere. But direct combined bypass carry the risk of post-operative hyperperfusion. If we do not notice hyperperfusion, patient may develop intracerebral hemorrhage. This is very misery complications. So we are very keen to prevent hyperperfusion complications for these 25 years. In regard to long-term outcome of STA, MCA, and EDMAPS, mean follow-up period was around 11 years, and annual stroke rate just 0.1%. This is the best result compared with previous clinical studies. At Hokkaido University, I also conducted translational research using stem cells. There are many drugs can treat ischemic animals, but almost no drugs can treat patient with ischemic stroke. Almost no neuroprotective agent. So I shifted my basic research from neuroprotective agent to cell therapies. I was sure that we can run first in human clinical studies using autologous bone marrow stromal cells. We conducted this study at Hokkaido University Hospital, and this was phase 1-2 studies. And we obtained bone marrow cells from the patient with ischemic stroke and cultured bone marrow stromal cells in cell processing center. And we labeled the cells with iron nanoparticles to visualize transplanted cell in the brain. So we treated these patients. And this cell therapy was very safe, and also we could for the first time visualize a transplanted cell on T2 star weighted image. Just after transplantation, we could see the transplanted cell at the transplantation site. But several weeks later, such black dot almost disappeared. But at 6 months after transplantation, we could see the transplanted cells close to the infarct area. So this image shows many labeled cells were migrating into the cerebral infarction, I think. Maximally, transplanted cell migrated up to 8 centimeters. Then I moved to Toyama. At the Hokkaido University Hospital, I just operated on a cerebral vascular patient. But at Toyama University, I could have the chance to operate on other CNS disorders. It was a very, very good opportunity for me. So, and I could concentrate on education, large-scale clinical trials, and also novel translational research. This is our more study to prospectively examine the long-term outcome of asymptomatic moya-moya disease. And now we can get several results about stroke occurrence. Stroke occurrence was 1.4% per year. This is a result of music study. I told the result of music study before, so I skipped this one. And another cell therapy. You know Muse cells? Muse cells is very powerful stem cells. And we spontaneously have the Muse cells inside the bone marrow. Muse cell can differentiate into all germ cell line cells, like ES cells or iPS cells, without any genetic procedures. These cells were found by Professor Mari Dezawa from Tohoku University, Sendai, and we are collaborating for more than 15 years. I show you the recent, one of our recent results. When we transplant the Muse cells through the nose, nasal mucosa is very, very good route to the brain. Nose to brain delivery of stem cell significantly and markedly improve the motor function of animals. And also, if we inject the Muse cells intravenously to the traumatic brain injury rat. So in summary, I was very, very happy for a lucky guy to have a chance of basic science and clinical studies and neurosurgery and also novel translational studies. I could publish such numbers of papers, and I can get such numbers of impact factor and so on. And I could have the opportunity to work as a co-chair of WFNS Education and Training Committee, and also president of Japanese Society of Surgery for Cerebral Stroke, and chair of a research committee of moya-moya disease in Japan. So
Thank you once again, Professor Kuroda. And for the vote of thanks, I would like to invite Professor Shashwat.
Thank you, Professor Vivek. It is my distinct honor and privilege to deliver the vote of thanks for 36th Sarveshwari Memorial Oration held today as part of the 28th AIMS Annual Microneurosurgery Workshop. First and foremost, the department thanks the family of the late G. Sarveshwari for their enduring commitment to establishing this oration, which continues to bring leading figures of neurosurgery to our institution. I extend our deepest gratitude to our esteemed orator, Professor Satoshi Kuroda, Professor and Chairman of Neurosurgery at Toyama, University of Toyama, Japan. And your oration was truly enlightening and inspiring. The insights you shared from your vast experience have enriched all of us present. Thank you for taking your time out of your busy schedule to honor us with your presence and your lecture. I thank the AIMS administration, led by Professor Girija Rath, for dutifully facilitating this oration every year. Thank you. Thanks to the delegates for joining in listening to this wonderful oration. Now I invite everyone to join us for breakfast and tea.